Is my screen visible?
Yes.
Okay, great. Okay, so I think welcome you all for today's exciting 14th eConnect we are going to happen. And this is the iStent forum where we have renowned speakers from Mumbai as well as Calcutta, and we have our panelists attending from south of India. So I would like to introduce our speakers first, and then I will hand over to Dr. Anujeet for his first presentation, and then Dr. So I would like to introduce Dr. Anujeet Pal here. So Dr. Anujeet Pal, he's currently as a consultant, working as a consultant, cataract and vitreoretinal service at BBI Foundation, Calcutta. He is an assistant professor at Krishna Mission Seva Pratishthan, VIMS, Calcutta. He's also a visiting consultant, BR Singh Railway Hospital and M. N. Chatterjee Memorial Eye Hospital, Calcutta. He is a great young ophthalmologist. He's a recipient of IGO Platinum Award 2021, TNU Gold Medal 2021, Dr. Ranjan Roy Young Ophthalmologist Free Paper Award in the year 2023. Congratulations, Dr. Anujeet, for this wonderful achievement. In his credit, he has already have 30 PubMed publications, index publications in national and international journals, and already wrote 2 book chapters as well. He is a section editor in Retina, Tamil Nadu Journal of Ophthalmic Sciences, executive committee member of Ophthalmic Society of West Bengal, and Calcutta Association of Ophthalmologists. He is also an executive board member of Young Ophthalmologist Society of India. So I would like to welcome Dr. Anujeet to attend this interesting meeting, and I think it is a second meeting for you, and
Yes.
I welcome you personally for this meeting. Let's go. We also have Dr. Hardik Patel. Hardik Parikh is from Mumbai, who is already attended. Thank you very much, sir, for joining this interesting meeting, and we are very proud to have you here today for this meeting. So he is a medical director. I'm very happy to say he's a medical director of Global Eye Clinic. His educations and trainings, MBBS from Topiwala National Medical College, BYL Naya Charitable Hospital, which is in Mumbai. He has done his MS in ophthalmology from Rajiv Gandhi University of Health Sciences, Bangalore, and FAICO, which is in LASIK, Fellowship in Advanced International Cataract and Refractive Surgery. So it's a really wonderful CV to be, we are going here. And year of practice, wow, 18 years. huge experience in terms of the, practice in ophthalmology. Say specialization, cataract, refractive, corneal transplant surgery, iStent surgery. Thank you very much, doctor, having supporting the patients day to day. And I think you have done everything other than VR. So you are actually covering most of the anterior part. And Dr. Hardik Paris is a distinguished ophthalmologist and is a medical director in Global Eye Clinic. As I said, experience, he has performed more than 25,000 cataract surgeries, over 15,000 cornea plastic surgeries. Thank you very much, sir. This is a really a nice, excellent CV which we are going on. His expertise lies in cataract, refractive, corneal transplant surgeries, iStent surgery, utilizing state-of-art technology in the ensuring precision and safety. Dr. Parikh is a renowned of his patient-centric approach, exceptional surgical skill, and commitment to advancing the field of ophthalmology. I welcome you personally, Dr. Hardik, for attending this wonderful meeting, and it will be a loving to hearing from your experience as well.
Thank you. Thank you for the kind introduction.
And I also have Dr. Lalita is from Chennai, who has already joined. So Dr. Lalita, she has done her BBS from Government Medical College, Bellary. She's a DOMS from Mysore Medical College, Mysore, and post DODNB Sankara Eye Hospital from Coimbatore. She is a glaucoma, done her glaucoma fellowship from Shankara Eye Hospital, Bangalore as well. She is now working as a consultant in glaucoma and cataract department in Shankara Eye Hospital, Bangalore, since 2010. She is having her interest on glaucoma implant as well as in MIGS surgery, done more than 10,000 phaco's and more than 500 traps, and many more MIGS and implant surgeries in her practice. Thank you very much, doctor, for joining from Bangalore today. And it will be nice to take your opinion when the discussion part will come. So by saying this, over to you, Dr. Anujeet, for your presentation. We'll continue the presentation, both the presentations together, and then we will continue the question and answer. I would request our audience who has already joined as of now, kindly put your questions in the chat room, or after the discussion also, you can open your mic and you can open your video, and also when we can ask the questions to our speakers as well as the panel. Thank you very much. Over to you, Dr. Anujeet, for your presentation.
Yes, thank you. Thank you so much, Rutanayada, and thank you, Glaucos, for this opportunity. Can you please unshare your screen so that I can share it? Indeed, a pleasure to be amongst such stalwarts.
I
Rutanayada,
will,
I think you need
I
to
have,
unshare.
yeah, I have unshared. Yeah, now you can share.
Yes, thank you so much. So, the topic that was given to me was mindset behind MIGS. So, I've tried to encompass as much as possible when it comes to helping someone transition from the regular surgeries and put MIGS in the spectrum of operative surgeries. I think, is my screen fully visible? Yes?
Yeah,
Yeah.
it is fully visible.
Right. So, once again, thank you, Glaucos, and thank you, Shutanai. So, what I would like to tell the audience and those listening in that MIGS is, sorry. So, MIGS is not new. In fact, it's been around for more than 10 years, but it has been gaining popularity because of the ease of use, overcoming devices, advancement in devices that have been happening over the years. And of course, the most important thing is safety as well as efficacy over the last couple of years. Uh, Are my slides moving? Yeah. So why does mindset come into being? So I think all of us can recognize what surgery this is. And for the longest time, we have been performing manual small incision cataract surgery and been touting it as one of the surgeries for providing vision. The first time when phacoemulsification came in, we were always skeptical about trying to figure out whether the safety and efficacy matches or not. There have been advancement in machines, there has been advancement in technology, but why did phacoemulsification take off over SICS? It took off because of the change in mindset. Advancements kept on coming one after the other, but it was our mind block and our mindset that changed, and we adopted a newer modality of surgery, providing better efficacy and safety for our patients. Mindset later, after a couple of years, became a mind shift. Why? Because phacoemulsification got the ability to advance once more. And now today we have femtophaco. With femtolaser, we can emulsify a cataract. That led to another advancement, the ability to implant multifocal and toric IOLs. So technology will always be there, but it is our perception of technology, both in terms of how we use it, as well as how we can benefit or our patients can benefit from it, that changes our mindset towards something like this. So glaucoma has traditionally been known as a disease that needs to be treated with medication, and medication is the go-to first-line treatment for glaucoma. Coming to some studies over here, it has been seen and proven time and again that addition of medication does not always be the effective strategy. The first medication causes a drop of almost 30 to 35%, but with addition of medication, the drop in intraocular pressure succeedingly decreases. This is the first disadvantage when it comes to medication and medicating our patients for years on end. Once again, we have reached a stage where if we have a long glaucoma practice, majority of our patients are on 2 or 3 topical medications. Barring the side effects, let's not even go there right now for the sake of the topic. Barring the side effects, if we just consider efficacy as well as safety, with each additional medication, it decreases. So that's the second disadvantage when it comes to medications going on and on and on. Therefore, why adopt MIGS? So the first thing is high safety profile. So here MIGS is competing with traditional filtration surgery. traditional filtration surgery does have a risk of hypotony, does have a risk of choroidal effusion and hemorrhages that is mitigated by MIGS. There is minimal disruption of the normal anatomy, therefore enhancement of the normal physiological outflow of the eye. Modern methods of MIGS do employ an ab interno approach, that is direct visualization of the trabecular meshwork and thereby bypassing the trabecular meshwork to maintain outflow. They have a considerable reduction in IOP. This has been shown variably in various studies, somewhere between 15% and 20% in some studies. Though it is inferior to filtration surgeries, they work quite well. With minimal downtime of the patient as speedy recovery, they do have a high compliance compared to medications. So just a revision for those joining in and want to know more about MIGS. The first thing is that we can enhance by bypassing the trabecular meshwork via the Schlems canal. We can augment the uveoscleral outflow by accessing the suprachoroidal space, and we can decrease the aqueous production by ablating the ciliary body. These are primarily the three methods that are currently employed for treatment of glaucoma surgically via MIGS. iStent is a device that is a trabecular meshwork bypass system. That means it bypasses the trabecular meshwork for direct access to the Schlems canal and collector channels. It is ideally two identical stents, roughly of a base diameter of 360 micron, that can be implanted through an injector, which has a 23 gauge sleeve. It is implanted ab interno at the trabecular meshwork. Two stents are implanted roughly 2 clock hours apart. So over here, glaucoma surgery has gone beyond the glaucoma surgeon. And as a cataract surgeon, what are the advantages for us to do a iStent procedure with or without our cataract surgery? So primarily indicated for open angle glaucomas, that is mild to moderate type. Some types of secondary open angle glaucomas like pseudoexfoliation and pigmentary glaucoma have been tried for MIGS. Usually, pseudophakic as well as phakic patients are eligible, and patients which have side effects to anti-glaucoma medications have traditionally been taken. It is important to make sure that your patient also has a normal angle anatomy and no peripheral anterior synechiae. It is easy to combine cataract surgery with patients that have been on 1 or 2 medications and have been long-term glaucoma patients with a very simple implantation of an iStent. So coming to mindset versus mind block, back to the topic that I was handed on. So mindset is when we have decided to undertake the procedure for a patient, and mind block is when we are not sure about the determinants of the procedure. For example, if we can perform an uneventful cataract surgery, the only mind block is surgical gonioscopy and understanding whether we can actually make the implant as well. So as a cataract surgeon, I urge, it took me a while to figure out surgical gonioscopy as well. But as far as the procedure is concerned, as I've written over here, is just 2 stents and 2 implants. So it's well known that the microscope now has to be adjusted. What I felt was a challenging case for me is the distance of the surgeon from the patient. Ideally, to get an on-fast view of the angle, the head of the patient should be tilted away from you and the microscope should be tilted towards you. So this is one of the challenges when it comes to orienting yourself physically when you are doing the procedure. Other than that, it is, well, like I said, a challenge between mind block as well as mindset. So some on-fast views of what's actually happening. So we'll come to the procedure shortly. So in an on-fast view, you can see that your left hand is actually holding the surgical gonioscope over here. So I have chosen to use the iPrism SX. There have been surgeons that have demonstrated that with a high molecular OVD on the cornea, sometimes they can go hands-free with the left hand. And with your right hand, since I'm a righty, you go in for the first click as well as the second click. You can see at the margin over here, there's not much of an angle difference between this stent, which I'm implanting second, as well as this stent that I'm implanting first. So it's important to note that it is a procedure that requires a lot of precision and a lot of concentration when you are implanting. Like I said, there is a 45-degree tilt of the microscope, as well as a 20-degree tilt for the patient, as well as one hand being most of the time locked in on the patient's cornea, with the second hand just managing a minute tilt on both sides to implant the iStent. So these are all the techniques, these are all the mind blocks that sometimes surgeons have while undergoing or doing the procedure for the first time. So this is a short video. I just hope I can. So I usually do side port incision, implant heavy molecular OVD, and then put some on the cornea, and then tilt my microscope. After putting the prism, you have to go in for a high magnification, and once you visualize the trabecular meshwork, you can implant each stent one after the other. So when you're implanting in the beginning, it's good to take a break, but once you get a good idea of it, when both stents are in place, in the TM you can get a good visualization as well as a good feedback. And it's important to also remove the OVD as well. So this is a video that is just about a minute, but I think my first stent took me around 15 to 20 minutes. Other than the factors which I've mentioned, the rest of the procedure is fairly simple. So this was the view from the operating microscope. So after all this, I'm sure there is someone in the audience who's asking this question, that my patient is just fine with drops. Why do I need to shift the patient? What is the reason? So I ask the audience, is it so? Is your patient really fine with drops? So why is a change needed? So beyond the factors that I mentioned right in the beginning about the decreasing efficacy of drops, there are some things that we also need to keep in mind. That is poor compliance and adherence to the drops, which is the primary complaint of glaucoma surgeons at most forums. Suboptimal 24-hour intraocular pressure control due to drops, as well as the changes that occur in the trabecular meshwork and outflow pathways that lead to irreversible fibrosis, sclerosis, and damage. So these are all not in our hands. Can we find a way to take this away from the patient and into our hands? So we can control the intraocular pressure, we can prevent the disease progression, and we can give the patient a better quality of life. So traditional legacy treatment, as it was previously and for the first time illustrated by Dr. I.K. Ahmed, was giving our patient medications, that is starting the patient on a single medication, then maybe shifting the patient on a second, and then a third medication and additional medications till we see that medications cannot be tolerated anymore. And then maybe take up the patient for SLT or a filtering surgery. This has been our paradigm for treatment for years on end. It's been the cornerstone for glaucoma therapy. And when our filtration surgery fails, we think of maybe an additional filtration surgery, and maybe we think of the tubes as well as shunts. So it's always been a medicine first protocol where surgery has always taken the back seat because of the complications involved and the risk of failure, as well as post-operative management of these filtration surgeries. So Dr. Aiki Ahmed also proposed a new paradigm for treatment, which we are now trying to bring in as interventional glaucoma. So when instead of starting the patient on medication, we can think of a new standard of care for the patient, where we think of SLT, though SLT is not very much performed in this country. Drug delivery is gaining a lot of popularity elsewhere. I think Glaukos is doing a lot of work with that and will be launching it soon. But if we can augment patients with mild to moderate glaucoma who are on a single or two medications with an MIGS procedure, keep them disease-free for the first couple of years, maybe more, and control their progression, take control of their compliance, prevent the side effects of medication. Then, if required, go in for a second MIGS procedure or bridge therapy with medications, and keep our filtration surgery still as our last resort. So instead of medication, take in the patient, explain the pros and cons of medication, explain the pros and cons of surgery, explain the long-term benefits, the long-term efficacy, and the long-term safety of both, and let our patient choose. So what's the data like? So I mentioned a lot about using iStents. I mentioned a lot about augmenting it with cataract surgery. So this is the data that I found. So this is a 5-year glaucoma control, and this study was published in 2022. And this is a 7-year efficacy rate of iStent, and this was published in 2024. So in combined surgeries, it is showing roughly around the 39% decrease, as well as in the standalone there is a 42% decrease in intraocular pressure. Similar results have been shown by both studies as well. So the data is also positive. There's a lot of data that is currently in the work in pre-publication stage as well that I'm aware of, and the data looks good as well. So traditionally, cataract surgery initially suffered a mind block when phacoemulsification came. Then there was a mindset change, and then there was a mind shift where now cataract surgery, we can only aim for the stars. We can think of flax, we can think of multifocal IOLs, etc., etc. So why not bring that change to minimal MIGS? Why not set the mindset right in the beginning so that there is no mind block, and then usher in a mind shift? So I like to end always by mentioning that we should be doing what the patient needs next. And MIGS is something that is here to stay. Thank you so much. Mr. Shrutanai, back to
Thank you
you.
very much. Thank you very much, Doctor. I think this is amazing, a fantastic talk by you. We will continue our topic discussion with Dr. Hardik Parikh now, and then we'll go for the discussion.
Sure.
And over to you, Dr. Hardik, for your presentation. In
Good
the
evening,
meantime,
everyone.
uh, in the meantime, requesting our audience, if they have any questions, they can definitely put it in the group as well.
Good evening, everyone. I think I'll have to just share screen first. It's a wonderful talk we started with. In fact, 90% of what I was supposed to talk is already covered, so I'm glad that I can skip directly to the point. Uh, just trying to share screen. Is my share screen on?
No, so we cannot see it yet.
Yeah.
Yeah. I think I'm facing some issues.
Sutna, can you help, sir?
Yeah, of course. Uh,
Uh, so when I go to sharing entire screen,
yeah, sharing the entire screen.
yeah, but I'm not
So share
getting,
your desktop directly. Then it will share everything.
but it's not giving me that option. It's just giving Chrome tab, window, and entire screen.
Yeah, then share your entire screen.
Entire screen.
Exactly. So when I go to entire screen, yeah, now I can. Okay.
Yeah.
Yeah, now it's sharing.
Yeah. So I think most of it is very well covered in the previous talk. I would like to highlight a few things. I'll be contributing as someone who's not a glaucoma surgeon primarily. I'm more of a phaco-refractive surgeon. But when I came across iStent, what attracted me and what made a difference to my patients also is that the dependency in eye drops, glaucoma drops, has been reduced because, as mentioned before, the efficacy, the compliance, and the side effects do affect on long run. Uh, the maintenance of IOP, there is very poor maintenance of IOP throughout the day, even with the drops, because there are spikes of IOP which have been recorded. So that we can control with the iStent at 24/7. And thirdly, it is a surgery which is closest anatomical replacement of the problem. We have seen a big change even in corneal transplant surgery, how we mentioned about cataract surgery, also corneal transplant surgery from
So sorry to
retin
interrupt.
keratoplasty.
Screen is not visible. So we are just seeing the Zoom screen.
Yeah,
Is that
no,
what you're sharing?
I think yeah, I'm just talking right now. I
Okay.
can, yeah. I don't have a slideshow prepared because I'll just directly go to a raw video. But what
Okay.
I'm trying to say is that anatomically closest keratoplasty today that we have is DMAC. But DMAC was preceded with DSEC, which was supposed to be superior than PK. And DSEC not only replaced optical PK in many of the indications, but why DMAC is more superior than DSEC is because it's anatomically the closest we can get to replacing the endothelium. Similarly, iStent is anatomically closest bypassing the trabecular meshwork, which actually is causing the raised IOP. So, uh, as a surgeon who is a cataract surgeon, I'll just show you a raw video of how surgery is done. This how I learned it. So this is, and I'll have to skip because it's not a. Can you see the video?
Yes, doctor. Yes.
We can. Yes, we can.
Okay. Okay. So just start. So basically, how I do it differently is I don't go for a big 2.2 incision. I do it through the side port incision. So 21 gauge side port is what I need. This is why, because we know that the angle which is required, rotational angle, which was very well shown in the previous talk, is hardly anything. But the advantage you get with the side port incision is that there is less shallowing of AC. So when you are a beginner learner, when you have less shallowing of AC, this is what it helps, because with a bigger incision, the more shallowing happens, you may have to come out again and put the OVD again and then continue. But the lesser the shallowing, the more maintained anterior chamber. So I always do at the superior temporal angle for the right eye, and similarly for the left eye, because I alternate my hand. For the right eye, do with my left hand. For the left eye, I do with my right hand. iStent implantation, but it maintains the anterior chamber very well. So I go ahead, and the angles as explained, you will see when you have the proper positioning of the microscope and the eye, the moment you put the gonio, the prism, you see the angle directly. And this is what you're seeing here. See, the moment you put it, I got the direct view of the trabecular meshwork. Right, and it's beautifully seen here. And this is what helps. So when you are training, make sure that you are getting the right angles, position of the eye, position of the head, and the position of the uh, microscope very well done. And I always first check the trabecular meshwork. I see that it's viewed properly, and then I go and prepare my eye stent. And I'll just go back and show. So I'm going through the 0.5 incision. I'm skipping few parts. You cross the pupil, then open the sheet, locate it. I don't give a very hard press, just gentle dimple. Make sure the newer ones have a very good view of the trocar. So you can see, and I implant the first eye stent. There it goes, and I retract back, release the push button, and then again go locate my second site. One of the things I learned is, whenever you are locating the second site, try not to touch the trabecular meshwork unless you're very sure where you're doing. And when you are very sure where you are going to implant, not only is it 2 clock hours away, you should be sure that you will be able to press the hand and the button without actually changing or uh, shallowing the AC. So once you get it, again dimple, and this is my second implant, and this is all in real time. And you see, it's not very difficult. It hardly takes some time. So you put back. Moment I implant, I stay there for 2 seconds. I just count 1, 2. I don't retract immediately, and I make sure retract. Once you are there, again put the sheet up, because you're crossing the pupil. This is especially important if you have a phakic patient. And once you're done, I retract, and you can see both the eye stents placed. I remove, I go back. Now we know one of the signs, and one of the what we expect is bleed from that site. So when we have bleed from that site, we have to wash it. But what I do is, since the OVD is there, I usually keep the OVD and don't wash it off immediately. I keep it there for about 2 minutes after the implantation. The reason is, once you have kept it for 2 minutes, I'll stop sharing now, because that was a video I wanted to demonstrate. The idea is that the the bleeding, it clots, it doesn't disperse. If you go and wash immediately, there's a lot of dispersion of blood, and this may deposit on the lens if it's a if it's a pseudophakic patient, and it may also cause some amount of haze post-op day one, which we don't want. We all know, as surgeons, minimally invasive surgery and immediate recovery of vision is something our patients look forward to. So this helps me make that bleeding, stop that bleeding, and make it a clot rather than actually a dispersed heme. And once I've done that, I go and gently wash off all the visco very slowly, no sudden decompression. So you have irrigation going on, but the aspiration is very slow, not like cataract, it's slightly slower. So that, again, I don't dislodge the blood clot. And then once I'm done, I just hydrate to see that, I'm seeing a blanch in the scleral vessels. So this is how I go ahead. I was also told to talk a bit about my post-operative regime. I, since the beginning, first since my first stent, have not been giving any anti-glaucoma drop post-operatively. And of course, I use the iStent for mild to moderate glaucoma. I'm not talking about severe glaucoma cases, but I don't put them on any anti-glaucoma medication, even if they are on, neither oral or topical. I start them on topical steroid like diflucor just twice a day and for 1 week only, along with the antibiotic, topical antibiotic. At 1 week, I stop the steroid and antibiotic also. So that's all the treatment I give. I measure the IOP at post-op day 1. If I get somewhere with the steroid at around 1670, I don't add a AGM. But if I get at around 20, I do add a AGM. And at 1 week, if I get IOP, when I stop the steroid and see them again at around, let's say, 8 to 10 days after stopping the steroid at 1 week, if the pressures are below 16, below 15, or below the target IOP for that patient, I don't add any HM. If it's above 17 or 18, I do start anti-glaucoma medication as indicated in that patient. This is what I do for post-operative regime, and uh, I have seen a drop of around average 18 to 20% IOP. My biggest drop was around 40% IOP. This case, what you saw, was preoperatively 21 with anti-glaucoma medication, postoperatively 18 with steroid, and 17 without the steroids, without topical steroids. So this is all I have to say for today. I think we can take questions now.
Absolutely, sir. I think it's a really nice way of communicating, doctor, and I would like to thanks you for bringing these very important, parameters when you are, managing your patients, particularly post-operative management. So this is really nice. And now I think we have Dr. Lalita as a panel for this meeting, and we have our audience. So now session is open. So anybody have any questions can put in the chat, or they can unmute themselves and ask the questions if they have. I already have some few questions. We'll discuss. Let's wait for some time for if the audience used to give any questions to us. In the meantime, to Dr. Hardik, so like questions you talked about, we have got a questions in WhatsApp comes to me
Okay.
that so the question is regarding you said about you are don't going to use any anti-glaucoma drugs
Yeah.
after the surgery. So
Right.
yes, so let's say if your patients are after the surgery after 2 months, 3 months, it's around 17, 18 earlier that become 2021. And have you seen this your patients in your practice, surgery you have done? And if it is so, what type of product, which type of molecule you want to give and why?
Yeah, that's a good question. So, I think about the number of cases I've done is not very great, not the numbers which we have, but I've done a decent number. And in those also, I've never come across a patient who has a raised IOP, and I've had follow up to the first case I did was almost more than 18 months now. So not got a single patient where I have faced a raised IOP till date. But of course, if you have a raised IOP, you should start on anti-glaucoma. Uh, how to start anti-glaucoma, we all know, of course, the indications, contraindications, depending on previous allergies or systemic history, etc. But yeah, you can start if the IOP is high.
Great. Now I would request Dr. Lalita to also give her input, particularly on these questions. Dr. Lalita has used few of the iStent, and what is your experience, doctor?
Yeah, what I do is usually I have not started any patient with post-operative, drops AGM now till now. I have a 6 months follow-up now. But if the pressure, we have already counseled the patient to use if it is required. So if it is required more than 20 or anything, then better to start even a timolol drops is also enough to control the pressure to around 20%. That's all I do.
Sure. Dr. Anujit, is it the same experience you also have, or you have a sort of different opinion?
So like Sir said, I do the same thing. Except for the first patient where I was a little bit on the edge, I kept the patient on anti-glaucoma medication for the first week because I didn't know how much of OVD I had actually irrigated and aspirated out. But for subsequently for the next 3 or 4 cases, all patients have been totally off medication. I think my longest follow up is around 7 to 8 months. I think it was July when I had done it, or July or June. And I think in that patient is also not on medication. So I think so far all the patients are doing quite well.
Excellent. So we have another questions in the group, and I will divert it to Dr. Hardik once again. So the question is, what is the percentage of pressure reduction by iStent which you can promise to the patient?
You can promise up to 20%. You can. As I said, I have few patients who got up to 40, but let's not overpromise. Let's promise 20% and see.
Yes, it is
And
always
if
good
we
to
deliver, then they'll be very, very happy.
yeah, it's always good to be
Absolutely.
under commitment, yeah, and
Absolutely.
over performance.
Yeah.
Yeah,
What you can say is that I say that you with this you'll be able to stabilize glaucoma very well. The idea is to bring it to a stage where you will be able to stabilize, because that is what I'm seeing. I'm seeing that and that's what even studies say, as far as what I know.
great. And Dr. Lalita, what is your opinion on this question? So what type of commitment you do to your patients in terms of iStent when iStent is being prescribed?
We under promise and over deliver. So you tell the patients around 20-25%, it will come down. So it will avoid definitely 1 to 2 drops. If they are using the 2 drops, we will see how the 3 drops will be come down or not. If required, we will use 1 drop, like that we counsel and keep it. So the definitely 2 drops, I am sure. That third drops, I don't know. That's why we'll wait and watch, and how the pressure comes depending on that. Usually 1 month steroid responder also will be there. So after the 1 month, you call them after stopping the steroids after 2 weeks or 3 weeks or 4 weeks. Then you check the pressure. Then you can decide whether to add on or not. Then take a call regarding that.
Sure. Dr. Anujit, is this opinion same for you also?
Yeah, absolutely. I definitely second this opinion.
Okay. So another questions now comes to Dr. Anujit directly. You said about in your presentations that when it comes to mix as a procedure, so maybe iStent is one of the mixed procedure, and there are other mixed procedures available, which is in the market, and there are few doctors and institutes are practicing it. What type of other mixed procedure you prefer for the cataract surgeon, and is there any reason behind it? Why or only iStent, or you want to give the options to the other mixed procedure when you prescribe to a patient?
So the other mixed procedure that has been doing quite well is KDB, that is Kahook dual blade, to it's called excision goniotomy. So to excise a portion about 2 to 3 clock hours of the trabecular meshwork. But I think as a cataract surgeon, as a surgeon of as any surgeon whose primary specialty is not glaucoma, who has not done enough trabeculectomies, who cannot manage beyond a certain amount, but has mild to moderate glaucoma patients, does practice some amount of medical glaucoma in their regular practice, and would like to take up, I still believe that iStent is one of the first and foremost choices. And the next choice is definitely KDB, but I would put it much lower down the list because in terms of invasiveness, iStent is the least invasive compared to the safety and efficacy that it gives, compared to KDB, which is slightly more invasive. There are cases of hyphema, etc. with KDB. Bang is even more invasive than KDB. So honestly, I would like the opinion of the panel as well, but I see KDB as a good second place. But I think if someone is well versed with iStent, then only should they try KDB. I'm yet to do my first KDB, but I'm quite interested because I'm interested in knowing, for academic reasons, the percentage of IOP falls, especially for my mild to moderate glaucoma patients, which I daily treat. But I still feel that KDB falls a far second, but that definitely is a good option.
Thank you, Doctor. Dr. Hardik, what would be your opinion here?
I would second that. I would definitely second that. I agree with him, and it's very minimally invasive. Also, one of the points Dr. Anujeet mentioned in his PowerPoint is that it brings about, of course, this is apart from this question, it brings about a good 24/7 control of IOP. Yeah, I agree.
Thank you very much, Doctor. Now we have Dr. Lalita, who is a pure glaucoma surgeon. We want to listen from Dr. Lalita also on these questions because we have two surgeons who are cataract surgeon and our panel is a glaucoma surgeon. So over to you, Dr. Lalita, for your opinion.
Yeah, I do KDB also. It usually gives little more IOP control in the post-operative period than that of the iStent, but more common complication is the hyphema. And sometimes the hyphema, the blood may not be there in the anterior chamber. Sometimes it goes beyond the IOL, and the blood clot will be there in between the IOL and the PC. I have personally myself have seen that, and I have also observed with other doctors also that becomes little challenging to wash the blood clot behind the IOL when the rexis is small for a phaco and exactly going behind that too after you want to wait for 1 or 2 weeks. But when 1 or 2 weeks we have waited and the blood clot would have become a thick fibrinous clot, it is very difficult to go behind the IOL and remove that clot. If it is simple a anterior chamber clot, it is easy to wash. That is one very difficult thing with the KDB. But otherwise, and initially, if the pressure is little more hyphema, means usually Dimox should be given for 1 or 2 days or 3 days. Then the topical AGM may be required in the first 1 or 2 weeks. Also, if the blood clot is there and increases in the immediate post-op period, we have to give the topical anti-glaucoma medication and even Dimox for 2 3 days also. And we have to observe the blood clots. Most of the time, blood clot will get absorbed in 1 week. It's a streak hyphema and very small one fourth of the clot will get absorbed in 1 week with the prednisolone eye drops. But the most common challenging complication is the blood clot behind the IOL and in front of the PC, which sometimes it may takes long time to get absorbed. If the patient visual acuity is less, then we have to take up for the resurgery to wash that clot. That becomes the challenging condition.
Thanks, Dr. Lalita, for detailed, response for these questions. So our next question in the chat books for Dr. Hardik. The question is: any tips to improve angle visualizations for microscope is still only 7 degree? The doctor, I don't know the doctor name because it's coming to the Samsung. I'm having Leica 620. Dr. Hardik, your questions.
Uh, the first thing to start, I mean, that's a very good question, and it's a very valid question because you have to visualize the TM, and once you get that visualization right, things are start. They start very smooth. The steps are very smooth. Uh, I don't have any experience with Leica, but with any microscope, first, whenever you do a training session, usually I believe still Psychic goes for training session, but I don't know. But whoever comes to you for a training session, just give your 100%. Just do it with discipline. Just make sure that you are getting everything right, especially uh, with the, I mean, of course, in the training session, microscope adjustment may not be that uh, realistic as it would be on a patient. So there is an angle which Dr. Anujeet said was 40/20. 20 the microscope, 40 the patient, right, Dr. Anujeet? I think so, yeah. But we actually take it as an angle where what I did was I took it as an angle where I did my first patient, gave it around 33-degree tilt of the eye and made him look nasally. And at the same time, I tilted what I did was I took the prism and I kept tilting the microscope till I got the right view. So I never followed any particular angles as such. Of course, the guidelines were there. And then I marked on the microscope the tilt which I got. So that's how I started. So there is another way which you can do it. I'm talking to Psychic to present that data soon. Uh, but once you have the tilt of your microscope marked and you get the right head tilt, uh, with the patient cooperating and looking there, you get the right view. I'm not sure how Leica would do in that, but I think it's a pretty decent microscope and you should be able to get the tilt right. So when you are doing the training, that is the time you uh, understand what angle of the head you want. In fact, for the first case itself, you first could probably spend 10 minutes, 15 minutes just how you can locate the angle at the tilt of your microscope and you'll get it right.
Thank you, Doctor. Dr. Kaivan Shah. Dr. Kaivan Shah, I think Dr. Kaivan Shah has asked these questions. Doctor, you want to ask any more? Want to get any more clarifications from Dr. Hardik?
I think they can speak also, right?
Yeah, they can
Dr.
speak.
Kevin.
Absolutely.
Dr. Kevin, does that answer your question?
Yeah, it was. Yeah, actually, I've been using since last maybe 1.5 year.
Mm-hmm.
I implanted maybe 15 stents till now and maybe more than 20 banks. So I'm managing somehow, but sometimes it becomes a bit cumbersome, mainly in very high myopic eyes. So the vision, the focus is changing a bit more compared to a normal eye. So, but it's a limitation I have to accept. Difficult to change the microscope just for the sake of iStent or a mix, but I am managing somehow.
But
I
in
just
high
wanted.
myopes, yeah, yeah, yeah. So in high myopes, I believe they would have a deeper AC. And you are saying it's difficult. It becomes blur in between the process.
Yeah, the because we are operating on high map, so the even the slightest change in the focus will,
Mm.
particularly when we are just implanting the point of implantation, that time when that dimple sets in, no, so that's
Yeah,
time just a small part of the time becomes a bit a blind procedure. But initially in maybe one case I lost all my 4 clicks just because of the poor visualization. But after
yeah.
that, I learned that the hard way, and then luckily I'm doing okay now.
That's a very valid point. So I got it. So when you do the dimple, because it defocuses, because it goes a bit deeper, you lose the
Because
focus.
the Yeah, because the
Yeah.
head tilt is I need to compensate the microscope tilt with the head tilt, because the seven beyond 7 degree my microscope will not move. So
Oh,
I need to compensate with the head tilt of maybe 50-60 degrees. So my hand is almost like going away from my focus, the lens. So
hmm.
I cannot, even with the eye prism SX, I cannot leave as it is, because otherwise it will fall the opposite
Got
side.
it. Got it.
So
Because it's a
so
big, big head
the
tilt. Yeah.
yeah. So the ergonomics are not that great in that position.
Okay. So I'll tell you one thing about the dimple. I most of the training videos that they have shown, you've done quite a lot of implants, so you'll understand. But the dimple is not really necessary. You just have to touch. You just have to land.
Hmm.
You really
Right.
don't have to dimple it. So just land like
Hmm.
just land it
Yeah.
there and just go for it. You don't really have to dimple. You just make sure the land is firm
Hmm.
because dimple actually is never helped me also. I don't think dimple is even required. And the newer videos, if you see, they don't show the dimple. So it was older ones which had. So uh, it's not necessary. So I think if you avoid the dimple, you'll be, I think, you'll be better off. Another thing, do you make an incision of 2.2, 1.8, or 2.4?
Actually, I operate through the this 23 gauge MVR only. I
Good,
just
wonderful.
slightly enlarge, so the AC does not become that much shallow during the
Wonderful, wonderful.
procedure.
So that's what you should use a 21 gauge MVR. Good enough. You'll never have a shallowing of AC. Never
Yes.
ever. Yeah, makes sense. Probably you can, yeah, what you can do is you can, and where do you put the incision? I mean, is it a supratemporal, like right eye, left eye?
Usually, mostly it is near to 180, not
So
very
we can probably put it
super.
supratemporal. See, let's say if you're going infranasal, I mean, the quadrant, let's say, is infranasal, try to go opposite that.
Okay, yes.
Going, if you have side ported temporal with infranasal, you have to go like
Hmm.
this with more dimple. You just go from here. So you'll have no dimple.
Right,
So infranasal, go supratemporal. Nasal, go
right,
temporal. So usually we put it in infranasal, just go from the 21 gauges supratemporal. And we'll have never have
right.
a
That is the best location of. Okay,
correct.
yes,
Yes.
yes.
Right.
Yeah, thanks a lot.
Sure.
Thanks, Dr. Kaiwan, for getting thing clarified. Thanks, Dr. Hardik. Also, we have a next questions. Does MRI this stent is MRI compatible or not? So I can answer this. Maybe you can also put this. Definitely, it is a MRI compatible. We have a 7 Tesla certificate inside the box. Definitely, after doing the surgery, you can surgeon can sign the certificate and hand it over to the patients. Patient can go for MRI scan if it is required after the stenting. Dr. Anujeet, any comments here?
No, not really. I think you only had told me maybe during one of our meetings that it is MRI compatible. So I think it has passed a lot of safety tests in general. So
Exactly.
no extra comments.
Yeah. Okay, and I have last questions in my WhatsApp that comes to Dr. Anujeet. Anujeet, you talked about the procedure. You said it's a very quick procedure and 2 to 3 minutes procedure. But what is the learning curve? If you tell to your new surgeons that what is the basic learning curve for this surgery? So maybe after doing cataract surgery, if you do cataract in 10 minutes, so what is the time they should keep for doing this mix, including the visualization and doing the stenting?
So firstly goes without saying gonioscopy as well as surgical gonioscopy should be practiced. Secondly, like Dr. Hardik sir said that your wet lab training just before this, Glaucos does an excellent job on training surgeons before their first iStent. I think these small parameters like your microscope as well as your bed, as well as your table, your chair, the height of each thing should be worked out. Thirdly, like I had shown in the video, but one thing that I'd forgotten to mention in the video is that the couple of seconds that you are implanting the eye stent is an extremely high concentration moment. I don't think I've concentrated so much during a nucleus. I think even chopping hard cataracts or some eyelid peeling or something like that, it requires a lot of concentration. Also, this is something that I felt myself, that when you are the surgeon and you are looking through your microscope, many of these surgeons does have a television in the OT, and there is someone from the team usually who's collaborating with you after maybe your first eye stent or your second, or maybe while you're doing your first. Is just a reminder to yourself that you've done MBBS and MS or DNB, everything. You know where the trabecular meshwork is. If you see it, and if your stent is at an on fast view, don't keep asking around that should I inject. You know the procedure, you've done it in the wet lab. When you're on the field, you just have to perform. So I see a lot of people asking and wondering and going back and going forth. Your left hand is also shaking, so those few seconds, just hold your breath, go in, implant the stent, come out. You know where the trabecular mesh was. Just tell yourself that before you implant the stent. Don't keep asking and confirming. That is the third thing. And finally, the most important thing is to just remember that you can slow down the procedure. And what I've seen is that when you are changing from one position to the other position, it is very imperative that you stay on fast. The second stent, in my case, there was a case, if you want, I can share the video where I had an implantation in the scleral spur. So that mainly happened because I started getting too over enthusiastic. So in case something happens which is not supposed to happen during your first implantation, There are ways of mitigating it. You can go in with a 23 gauge forceps and reimplant it. iStent Infinite has multiple implantations, as I'm told, when it comes to the country. So these are the few things that you need to keep in mind. Your ergonomics are very important. I cannot stress this more, that you are in a very ergonomically poor posture when you are doing the surgery. This is something to remember all throughout. And it's important to just stay extremely mindful when you're implanting. That's all. And it's not a difficult procedure. I made it seem like it's extremely difficult, but it's not difficult. All my stents have taken me somewhere between 5 to 10, maybe 12 minutes. So it's not that difficult.
Thank you. Dr. Hardik sir, any comments from you, particularly on this question?
No, I mean, yeah, your learning curve is important. As I said before, the first case you do, give it your 30 minutes, 40 minutes, 1 hour, 1.5 hours. Just make sure you have everything in position, the head position, the microscope, everything, and then you go ahead and eventually you'll keep learning. Of course, my first case, what I did was I did a bigger incision, and then I realized you don't really need a big incision, you need a very small incision. And that helped me from the second case because my AC didn't collapse much. You may feel the air may not come out through a small incision if you land up injecting, but if you saw my video, I could remove the air easily. Or even if you can't remove the air, trust me, you can just push the air to a side which is not infronasal. It won't hurt you. Uh, what you have to do is the right case selection and go to the right base, go to the right technique at this beginning, and then it's the learning curve may look steep, but it's actually not. You just have to go this, and then it just goes up. So give it all, give your first kiss everything, I would say.
Great, great. And I'll go to Dr. Lalita once again and try to get her opinion, because Madam has already done quite a few number of iStent and having a good experience. Over to you, ma'am, for your experience.
Yeah, usually the head tilt is very important. So usually company people also tell initially like 35 and 35-degree head tilt and 35-degree microscope tilt, but it becomes 70-degree tilt. Then sometimes the normally KDB and all it is more useful, but for high stand the head tilt should be less than that. Usually 20 degree is enough, and around 35-degree of the microscope tilt is enough. Around 55 degrees ideal they tell, and that should be this one. So initially they used to tell the patient's head should be on, they should be lying on their ear, like that they tell. But now it is like 20 degrees ideal, so we can put. But as we are putting in only one hand, left hand we are holding the eye prism, right hand you have to use it. So you have to balancing with the one hand is more important, and usually it causes the tremor also during putting the eye stent. So during the tremor, trocar bias can also happen, and it may not get implanted also. And sometimes what I felt is over implantation also can happen. Over implantation also can happen, but even over implantation also I have seen the stents are working. So it is working, and IOP control is good.
If I
Great.
may take a minute, I
Please,
think,
please.
Dr. Lalita, would you agree that over implantation happens if you put a very strong dimple? Because that's what I feel that happens. If you have a very strong dimple, that is what happens. And
Yeah, correct. Sometimes,
yeah,
yeah, as we are balancing with,
correct. So just a small
yeah, that's
landing
what
rather
over
than
implantation also can happen
yeah.
sometimes.
And the other hand, when you're holding the prism,
Yeah,
if you have a one
that's what
point,
initially few cases.
yeah, please, madam, go ahead.
Nothing. That's what. Initially, few cases over implantation is also a side effect or complication of that.
Right.
So exact landing and exact this one will be a difficult. After some 4 or 5 cases, you will be understanding how much to dimple, how much to hold it, and how much to press. So minimum 4 or 5 cases, according to me, you need a learning curve.
Correct.
And the KDB learning curve is more easier than that of the iStent. iStent is requires more learning curve.
Right.
Thank you.
And
You
and
can discuss.
yeah, and the prism where you're holding, I feel if you have a good 1.4% sodium hyaluronate on the cornea, and you just have to give it a support. You don't have to press the prism, just like this, just to support so that it doesn't fall off.
Yeah.
That's all. So if you don't do that, again, you avoid dimple. There are three things I learned to avoid maintaining AC and avoid dimple. One is putting a small incision, which I mentioned before. Making the incision right across, like if it's infranasal, make it supratemporal. Don't keep it temporal. And second is do not press. So these three things I think works really well. It should help in the learning curve.
Wonderful, doctor. Wonderful. I would request any other doctors who are a part of this event want to ask any questions. It is free. We will take last questions. It is already 9 o'clock. So, any questions from the audience? If not, can we close this, doctor? Now, it is the
Yes,
9.
thank you. Thank you all.
Thank you.
Yeah.
Thank you.
Wonderful.
Thank you very much,
Sure,
doctor.
thank
Thank you
you.
very
It
much,
was
Dr.
very
Hardik. Thank you very much,
wonderful.
Dr. Lalita and Dr. Anujeet for wonderful presentations. And I would say that this is really going to help our new surgeons who are coming with iStents, and really they are going to come across and going to help a lot, particularly for this event. Thank you very much. Great. Good night to all.
Thank you. Good night.
Thank
Good
you,
night.
sir.
Thank you.
Thank
Good
you.
night.
Thank you. Bye.
Good
Thank
night,
you.
sir.
Good night.